Christopher is here already. Yeah. So up next, we'll ask Dr. Christopher Go to talk about his project on evaluation of the health economics and patient experience of day one post-vitrectomy visits to assist in the implementation of a national guideline. Chris?
Thank you. So my project is looking at removing day one post-vitrectomy surgical review. So what's the problem that we have? So day one post-operative review is becoming more and more of a problem in the VR unit because of the increased surgical volume. So it used to be that we were doing 2 cases for the whole day, but now we're routinely doing 7 cases. And because of that, we have to see more post-op patients. We're delaying OT or clinic start time. Patients are waiting for a long time for a day one review that often takes less than a minute. And unfortunately though, because of the different age of the VR surgeons amongst the unit, there's a lack of consensus of what should be done. So some of us are doing no day one post-op and some are doing more than others. And during COVID, or maybe even before COVID, day one post-operative review for cataracts were all sort of out the window for a lot of the different countries, and we are basically modeling to see whether we can do something similar for VR surgery. So just a little bit of background, it is standard of care to have day one post-op review for quite some time ago, and that's because in one of the landmark paper back in 1988, there was more than half the patients have complications. But 1988, they were doing general anesthesia for VR surgery, they're doing large gauge vitrectomies, so a lot of the complications actually come from general anesthesia problems like pain, nausea, and vomiting. That doesn't apply nowadays to when we're doing VR surgery. So 63% of surgeons in the British VR Society did a survey last year, and 63% of us do not see the day one post-op reviews routinely. Yes, there are patients who will still see, but routinely, so for our routine epiretinal membrane, macular holes, we do not see these patients. And that's because of those things I've mentioned, local anesthesia, smaller gauge anesthetics. We kind of know what the patients are going to do. So that's what we're trying to do, see whether we can change the system within our unit. Like I earlier alluded to, is a large unit with 9 surgeons, so some older surgeons are very reluctant to do that, some of the younger surgeons are more willing to accept change. Patient safety and basically cost effectiveness and patient experience are the 3 pillars that people have been arguing about on whether these changes are good on all these fronts. So because of that, the unit ourselves basically went about finding out, addressing the concerns. So patient safety, what we did as a unit, we went back through the last 12 months, did a retrospective study, and see how many of these patients did we really change management on day one post-operative review. And what we found is that actually if you eliminate those with glaucoma and ocular hypertension, we didn't really change day one post-op review in terms of what we do. So the patients who had day one intervention is because they have high pressure, but those patients tend to have a history of ocular hypertension or glaucoma. Then we looked at, then after that we looked at, after we implemented allowing not seeing day one post-op and see whether there was increased adverse events, and we didn't find any. And so because of that, we said actually patient safety-wise, it's actually okay. But then what about the cost effectiveness and the patient experience? Are the patients going to be too anxious? They don't know what's going on. They will want to be seen by someone to reassure them the next day. All those things need to be figured out before we implement this policy. So we did a literature search. Interestingly, there's actually very little in the literature. So even for the cataract day one post-op reviews, even though a lot of us are no longer doing it, there's actually not much literature to support whether that's safe and whether that's cost effective. But it's just that something that we have done and it seems to have worked, but there's actually not much publication on this. So what do we do? And as clinicians, we don't really know what to do with this. So we needed help, basically. So what we did was we consulted a health economics professor that one of my consultants know, and then we basically came up with a novel pilot study to study the patient experience as well as the cost effectiveness of removing day one post-op review. So what did we do? It's a single-center prospective pilot study looking at patients who were the control group, which is the conventional way of having day one post-op review, as well as the routine 2-week review, versus those who didn't have any day one review and just go straight to a 2-week post-op review. The primary outcomes are looking at the cost effectiveness. So we developed basically a survey asking about the cost associated. That includes hotel stay, carers taking off time to take the patients to reviews, transport costs, all those things that we ask about the patients. And then we look at the quality of life of these patients as a generalized to see whether they perceive to be any differences, whether they get a day one post-op review. These are the baseline characteristics. So you can see that they are all very similar. There is more patients in the standard of care group, which is the one with day one post-op review. And in terms of the gender and the age, they're all very similar. Interestingly, distance to treatment center was slightly longer in the standard of care, which would have meant that the cost would have artificially increased because they have to travel further. And we thought that it's important to see whether they had any previous eye surgery, because that would change the patient experience, because maybe they're more happy to not be seen day one post-operatively. So the cost effectiveness analysis we looked at, essentially the first row on the NHS, the intervention group is half the price of the control group because there's one whole clinic review less. And the societal cost was what we talked about in terms of the survey, whether there's hotel cost, travel cost, all those things to look at. In the intervention group, the reason why they have problems is, or not problems, they have cost is because at the they might have called the hospital for opinions, or they have presented to the emergency or pharmacy to ask about their surgeries. And combination of those two, you can see that each patient saved about £100 per patient. And in terms of the quality of life, you can see that there's a very minute difference in that there's slight perceived reduced quality of life in the patients who didn't get a day one post-op review. So what does this all mean? In cost effectiveness analysis, what we actually found is that anything above that red line would mean that they are cost effective, because they are either less cost and more effective, or more cost but more effective. But our study is a little bit different because we remove something, so it's less costly, but it's also less effective. So we don't really know what that really means, but when you look at the probability of the cost effectiveness, it appears that it is helpful. There are limitations to the studies, so we assume that they have same quality of life to begin with. The intangible costs that we talked about, like delayed OT start time, patient anxiety post-op, and environmental costs for travels as well. So summary, we think that there's reduced costs, only slightly less efficacious for the patients, and if we implement this system-wide, it definitely is a significant cost saving. Progress-wise, day one post-op review no longer routinely required, although some surgeons still request for that routinely, but it's surgeon-dependent. We have 2 publications coming to publish that and see what the response is going to be. And we are now trying to get a nationwide policy to say that this is safe and that it is something that's safe to do. Lessons learned from all of this: 1, teamwork and collaboration. So when we were stuck about the health economics and the patient experience, we really didn't know what we should be doing, and asking health economics to help us and give us guidance on what to do really helped. Implement change with evidence, as we all do already, and the funding is the part that's probably the hardest, because all of this was done sort of outside of work hours with no extra help available, and the health economists did this pro bono. And if we want to do anything larger study to really make sure that this is working, we will definitely need funding for that. Thank you.
Thank you. Maybe we have time for one question for Chris. I'm not sure if you're aware, but I think the Canadian group did a study last year on eliminating day one as well. And they showed that there were very little difference in terms of complications that happened. So it's very interesting. As a VR surgeon myself, it's really time consuming to do day one. So very interesting. We'll see what happens with the policy.
Thank you.
Thank you. Great job.